Professional communication and medication safety. Introduction to the module. Professional communication is essential in healthcare to ensure that all healthcare professionals who are caring for the same patient share the same information and that any potential problems associated with their care are resolved. According to recent studies, one of the top causes of medical errors and patients getting harmed is inadequate communication among healthcare workers. Communication problems were found to be at the root of almost 70% of sentinel incidents. Learning objectives. After completing the module, you should be able to recognize the medical discrepancies that occur on the hospital admission. Relate medication discrepancies associated with transfers within a hospital. Measure the significance of medication discrepancies during or after hospital discharge. Figure out potential causes of medication transfer problems. Medication discrepancies on hospital admission. When patients are admitted to a hospital, it is essential to obtain the home medication list, including not only the medication the patient is prescribed, but also information on over-the-counter, for example, non-prescription medication, contraindicated medication, for example, due to a prior adverse drug reaction and drug allergies. When a patient is admitted to a hospital from primary care, the community pharmacist and general practitioner, GP, collectively have most of the relevant information on the medication use of the patient. However, the records from community pharmacists only reflect dispensing histories. For example, when a patient speaks to their GP about a complaint that may indicate an adverse drug reaction and is told to stop the drug or lower the dosage, this new information typically fails to reach the community pharmacist. Furthermore, a patient may visit multiple community pharmacies. The GP records may also be incomplete because of multiple prescribers. This information could be available to the community pharmacist, but may not reach the GP. Ideally, the patients themselves would be the best source of information, but this is also not always applicable, for example, in critical illness. The best way to obtain information on the actual medications used before hospital admission would be to combine as many sources as possible. This is not an easy task, as sources may conflict. This also explains why many medication discrepancies are often defined as differences between the in-hospital admission medication list, for example, the list of medications composed after hospitalization but before new prescriptions are added. Moreover, the home medication list, for example, the list of medications the patient actually uses in the pre-hospital setting, can occur at the point of hospital admission. Many of the cases included both unintentional and intentional medication discrepancies, but only unintentional discrepancies should be included as a true discrepancy. Intentional discrepancies are the result of treatment changes carried out by the physician and are, therefore, less important in terms of patient safety, provided the reasons for the treatment changes are documented and appropriate. The best possible medication history list should be created by using as many sources as possible, including information from the GP, the community pharmacy, the patient, and by checking the labels on the patient's medication containers. This should be compared to the medication list obtained immediately after admission to focus on unintentional discrepancies rather than therapeutic changes, for example, intentional discrepancies and all types of medication discrepancies, omissions, commissions and formulation, dosage, and frequency changes should be found there. In addition, over-the-counter medications and information on drug allergies and contraindications should be included but reported separately. Medication discrepancies associated with transfers within a hospital. Common patient transfers are seen between the emergency department and inpatient wards. Besides, general wards, ICUs, operating theaters and inpatient wards are the places where patients are usually shifted according to necessity. In many hospitals, these different clinical areas use different medication systems. Even within the same hospital, patients can be transferred from one ward to the other. For example, when computerized prescriber order entry, CPOE, is implemented, emergency departments, ICUs, and surgery theaters are often exempt from implementation or use their own tailor-made systems that better accommodate their specific patient processes. This means that transfers between these departments and other wards can be particularly prone to medication discrepancies. Medication discrepancies on hospital discharge. At the time of hospital discharge, a current medication list should be prepared, ideally including and differentiating the following. Discontinued hospital medications, for example, hypnotics. Discontinued long-term medications, together with the reasons for discontinuation, for example, due to ADRs. Details of newly started long-term medications that will need to be continued. Ongoing long-term medications that are to continue unchanged. Specified duration or stop dates for short-term medications, for example, antimicrobials, antiemetics, and analgesics for acute pain. Details of allergies, compliance aids, and future monitoring requirements. The revised medication list needs to be communicated to the healthcare professional and the patient, preferably before discharge. The healthcare professional should then update the patient's medication record with the new information. Because at least one medication discrepancy affects 14 to 84% of patients at discharge. Medication errors can have a wide variety of results, from no noticeable symptoms to death. Itching, rashes, and skin deformity are some of the symptoms that it might produce, either temporarily or permanently. Potential causes of medication transfer problems. The potential information illustrates that medication transfer problems can arise at every transition point in healthcare, even within the same hospital. Medication-related causes. The use of several medications is a well-known risk factor for medication errors in general. The more prescriptions a patient takes, the more likely something will go wrong. This holds for medicine transfer mistakes as well. Some specific categories of medication are more prone to error, especially medications with irregular dosage regimes. The mistakes with methotrexate for rheumatoid arthritis are notorious. The correct dosage of once weekly can be inadvertently transcribed as once daily, with, sometimes lethal, detrimental effects for the patient. Errors are particularly common in pharmaceutical names that seem or look comparable. For example, Losec 40 mg, omeprazole, a stomach acid inhibiting drug, can be accidentally switched to Lasix 40 mg, furosemide, a diuretic. Furthermore, the patient may not always understand what information is crucial to give. For example, over-the-counter medication is not always viewed as real medication and hence is not always shared with healthcare practitioners. Patients may also not consider certain formulations, such as transdermal patches or ear or eye drops, to be medication or may not wish to share details of herbal or similar medicines with conventional medical practitioners. Finally, patients may assume that healthcare professionals automatically know which medicines they are taking and not realize the importance of keeping a list themselves. Information technology-related causes. Although introducing CPOE systems together with clinical decision support systems can lead to safer prescribing, these systems may also contribute to new medication errors. Individual groups of healthcare providers frequently operate their electronic medication records. GPs have their system, community pharmacists have their system, hospitals have their system, and even within hospitals, various departments may use different methods. Due to the lack of an integrated healthcare information system, communication gaps arise that necessitate the application of alternative, non-information technology-based communication routes. For example, when patients are admitted to the hospital, the medication record from the community pharmacy may be printed and then faxed to the hospital. Subsequently, the fax is used for medication reconciliation when all medicines need to be re-entered into the medication system of the hospital. This is, therefore, an error-prone process with multiple transcription steps. Additionally, because the information is not being transferred electronically, additional labor-intensive steps are needed to document the transferred information in the right location in the hospital or GP system. A final problem arises because of the original purpose of community pharmacy records. They are mainly dispensing records, providing an overview of all dispensed medicines, whether this medication is actually used by the patient, and what dosage is not recorded in these community pharmacies systems. However, these records are frequently misinterpreted as records of actual use, which can lead to mistakes. For example, a patient may have been prescribed morphine slow-release tablets 10 mg twice daily, but due to increased pain, he consulted his doctor, who advised him to increase the dosage to 20 mg twice daily, for example, 20 mg twice daily. As the patient still has enough tablets at home, they can increase the dosage without informing the community pharmacy, so, in their system, the incorrect dosage of 10 mg twice daily will persist until the dispensing of a new prescription with updated dose instructions. Healthcare professional-related causes. In order to transfer information on medications, adequate professional communication is essential. This applies to the doctor, doctor communication, and the pharmacist, pharmacist and pharmacist, doctor communication. Physicians and pharmacists agreed on the barriers to collaboration. They both regarded lack of time and financial compensation and the need to collaborate with multiple physicians or pharmacists as the most significant barriers. Successful communication will involve respect for each other's preferred mode of communication and attention to the barriers to collaboration. Highlights from the module. When a patient is admitted to a hospital from primary care, the community pharmacist and general practitioner, GP, collectively have most of the relevant information on the medication use of the patient. Intentional discrepancies are the result of treatment changes carried out by the physician and are, therefore, less important in terms of patient safety, provided the reasons for the treatment changes are documented and appropriate. The best possible medication history list should be created by using as many sources as possible, including information from the GP, the community pharmacy, the patient, and by checking the labels on the patient's medication containers. The healthcare professional should then update the patient's medication record with the new information. Thank you. You have reached the end of this module.